My name is Ben Scirica. I'm a cardiologist at Brigham and Women's Hospital and an investigator at the TIMI study group, and I'm going to present an update on acute coronary syndromes, focusing on antiplatelet therapy as well as anticoagulants in 2017. Here are my disclosures. And what I'll do is first give an overview of how we think about acute coronary syndromes in 2017, and then break down the treatment specifically for unstable angina, non-ST elevation MI, look at ST elevation MI separately, and then briefly talk about cardiogenic shock and secondary prevention in patients who have had an acute coronary syndrome. So when we think of acute coronary syndromes, we're now talking about over 1 million hospital admissions each year in the United States alone. Most of these are diagnosed with myocardial infarction, though there still is a substantial number of patients who are diagnosed with unstable angina. With the introduction of the more sensitive troponin assays, we're likely to see less unstable angina and more diagnosis of myocardial infarction over the coming years. Now, acute coronary syndrome really is a spectrum of presentation based on one underlying pathophysiology, and that is the acute thrombus in a coronary artery. And that thrombus happens when a cholesterol plaque either ruptures or erodes and allows a thrombotic event to occur within the artery. And if we're looking at a total occlusion on the right of the slide, you can see the classic ST elevation on the EKG, and this is deemed an ST elevation acute coronary syndrome, and there's clearly elevation of cardiac biomarkers. On the left, you can see the partial obstruction of a coronary artery that typically leads to a non-ST elevation acute coronary syndrome, either with ST depressions, T-wave inversions, or in some situations, no EKG changes. And these are associated with lower levels of cardiac biomarker elevation. And from this initial diagnosis of ST versus non-ST acute coronary syndrome, we then get the final diagnosis of unstable angina, non-ST elevation MI, or ST elevation MI. The old nomenclature of Q-wave MIs and non-Q-wave MIs have really been retired because the Q-waves really are a very blunt metric of infarction, and there are patients who have ST elevations who do not develop Q waves, and those who have non-ST elevation on admissions who develop Q waves. So it is not a good way to distinguish patients. Now, when we're looking at a patient who has suspected ischemic pain, we really are looking at 4 different modalities in the evaluation. First, what are the clinical findings? Is it classic pain that's ongoing? Is it atypical pain? Is it exertional pain? What does the ECG show? Is it no changes? Are there some ST and T wave changes, and in particular, are they dynamic? Or is there frank ST elevation? We also look at the cardiac biomarkers, and then after using those first 3 clinical modalities to try to stratify patients in terms of ischemic acute coronary syndrome, yes or no, we then do a risk assessment. What's their risk of having subsequent cardiovascular events? And we define that usually as low, intermediate, and high risk, and then those patients with ST elevation MI. Now, myocardial infarction has a clear diagnosis and definition in something called the universal definitions of MI that are constantly being updated. To have a myocardial infarction, there has to be evidence of ischemia, clinical evidence of ischemia, as well as an elevation of cardiac biomarkers above the 99th percentile in a healthy population. And that's the diagnosis of a myocardial infarction. Now, we subgroup myocardial infarctions by the different etiologies of that ischemia. A type 1 myocardial infarction is called a spontaneous MI that's related to ischemia due to a primary coronary event, meaning plaque erosion or rupture. And that's the classic MI that I showed you beforehand. And that's the one for which all our guideline-directed therapies are focused on, this ischemic event due to a primary coronary thrombotic event. The second most common type of myocardial infarction is the type 2 MI, which is an MI due to demand or increased oxygen demand or decreased supply. And this means from anemia, arrhythmias, hypertension, heart failure. And these are the common MIs that we see in hospitalized patients. It's important that the treatment for type 2 MIs is usually not related to the antiplatelet and anticoagulant therapy that I'll discuss, but it's more related to trying to reestablish a normal oxygen supply and demand equation in the coronary circulation. Type 3 is a unexpected death, likely from an MI. A type 4 MI is associated with PCI and stent thrombosis, and type 5 is an MI associated with CABG. But to summarize, we're really focusing in this talk on type 1 spontaneous myocardial infarctions. Now, biomarkers really are a key aspect to the evaluation of patients with suspected ischemic chest pain as well as acute myocardial infarction. And you can see there are the different patterns of biomarker release, with really troponin being now the most sensitive and the most important biomarker. It rises rapidly, it will go quite elevated, and then it will have a long tail before it returns to normal. Newer generation troponin assays that are now available in the United States will be detectable even at an earlier stage than the conventional troponin assays that we have now, and they will stay elevated for longer because of the assay's ability to detect even smaller levels of circulating troponin. But remember, not all troponin elevations are acute coronary syndromes, and as we get even more sensitive troponins, history is the key to diagnosis. So we have to recognize the pattern, which is typically a rise and a fall in somebody who comes in with an acute coronary syndrome. Now, the good news is, in terms of the treatment of myocardial infarction, we have seen lower incidences of MI over the past decade. In particular, ST elevation MI has declined significantly since the 1990s. There's been a bump in non-ST elevation MI, but overall, the general number of myocardial infarctions has declined, likely due to better treatment with aspirin, statins, and other cardiovascular risk prevention strategies. We've also seen a decline in MI and mortality following MI in the 2000s, and this has continued over the past years, and this is again likely related to better initial management of the myocardial infarction and more appropriate and complete secondary prevention of myocardial infarction after somebody has their first MI. Now, when we talk about the different anticoagulation and antiplatelet therapies in acute coronary syndrome, we have to go back to some of the basic biology of the coagulation cascade, antithrombins, and antiplatelet therapy. And here we have the different pathways of the coagulation cascade, the tissue-mediated extrinsic factor, and the contact factor intrinsic pathway. And we can see that using the direct drugs like unfractionated heparin, we block both 10A and 2A, or thrombin, so they are a dual inhibitor. Low molecular weight heparin will inhibit a little bit more 10A compared to 2A. There are drugs like bivalirudin, which will directly block the thrombin or factor 2A, and drugs like fundopyrinox and the direct factor 10A inhibitors, which obviously are much more focused on the 10A. And these different agents will block the coagulation cascade either through 10A or 2A inhibition. Thrombin down at the bottom will stimulate platelet aggregation, and that's where we get then into the antiplatelet therapies, which I'll talk about on this slide. The platelet is a very complex, small little piece of sludge that we see on the slide. It has several phases of activation, aggregation, and then amplification. And what happens is that we, with our different agents, try to stop the activation, we try to stop the amplification, and then we try to stop on the far right the aggregation of the platelet with fibrin that causes the clot in the coronary artery. And we block the platelet through several mechanisms. With aspirin, we inhibit COX-1, which produces thromboxane A2. With the ADP antagonist of clopidogrel, ticagrelor, and prasugrel, we block the P2Y12 inhibitor. With the 2B3A inhibitors, we block the 2B3A receptor, which binds with fibrin. And then there even is a thrombin antagonist, which blocks the PAR1 receptor called vorapaxar, which is used in secondary prevention of myocardial infarction. So let's focus now on non-ST elevation acute coronary syndromes, because when we write the guidelines, we tend to separate non-ST elevation versus ST elevation. So first question about treatment of acute coronary syndrome is aspirin. It's the oldest therapy we have. There are still wide disparity in the use of different doses. I'd say the summary right now is the best dose for somebody with an acute coronary syndrome is to get 325 milligrams once in the ambulance or in the emergency room, and then they should never get more than 100 milligrams thereafter. And that usually means 81 milligrams in the United States. And that's because there's no more efficacy with higher doses of aspirin, there's just higher risk of bleeding. And in this data, from a study that looked at different doses, you could see that higher doses, whether it was with or without clopidogrel, was associated with higher rates of bleeding. Even with this data, we still see in the United States, 2/3 of patients in the green are still getting 325 milligrams at discharge. And so this is just an area that we could systematically improve and get people on 81 milligrams where they would get the same efficacy without any, and avoid any excess bleeding. Clopidogrel is been one of the mainstays in the treatment of acute coronary syndromes and especially non-ST elevation MI, and it really comes from one study called the CURE study, which looked at patients with 12,000 patients who came in with non-ST elevation MI. On the top left, you can see the primary result. In all the patients, there was a 20% risk reduction in the risk of cardiovascular death, MI, and stroke. This benefit was seen even in those patients who were just managed medically on the top right, and in patients who were treated with PCI on the bottom left, and even those patients who underwent CABG and continued on clopidogrel afterwards had improved outcomes with clopidogrel plus aspirin versus aspirin alone. And based on this, clopidogrel was and has always been one of the foundational drugs in the treatment of acute coronary syndromes. Now, the one issue with clopidogrel is we use the same dose, 75 milligrams in almost everybody. We either give 300 or 600 milligram boluses, but what's interesting is that there is wide variability in the clinical response to clopidogrel between patients. And if we look at these histograms here, they are actually histograms of platelet reactivity when the same dose is given to several patients. And you can see there's a wide spread. And within 2 hours, 24 hours, and 5 days, there are still a significant number of patients who would be turned clopidogrel resistant, meaning that they have not had the conversion of clopidogrel to its active metabolite. And at 24 hours, that can be up to 1/3 of patients, and even at 5 days. And so even though we're giving clopidogrel to many of our patients, up to 1/4 may not be of the patients may not be getting the effect that we want them to. Now, what are the reasons why there is this differential variability in terms of platelet reactivity after treatment with clopidogrel? Clopidogrel is a prodrug. It has to be metabolized in the liver by the CYP system. There are different genetic mutations leading to different SNPs that can have either patients who are very good metabolizers or very poor metabolizers of the active drug. In addition, there can be drug-drug interactions that affect the metabolism of clopidogrel. This all leads to the variable response when there is stimulation. And then there are other things we know that impact response to ADP stimulation of the platelet, renal function, age, BMI, diabetes, that all will make a heterogeneous response to clopidogrel in patients. And this means that there are different clinical outcomes based on this heterogeneity in response to clopidogrel. An example of a genetic mutation that leads to differential metabolism of clopidogrel was seen in the Triton-TIMI-38 study. And in this study, those patients with the CYP2C19 reduced function mutation, meaning they didn't metabolize clopidogrel, actually had higher rates of cardiovascular death, MI, and stroke compared to those patients who had the wild type. And you can see it was almost a threefold increase of risk of cardiovascular death, MI, and stroke in those patients who had a loss of function mutation and therefore could not metabolize clopidogrel normally. Now, there are a couple ways to get by this heterogeneity in treatment. The first is to give more clopidogrel, so that's why we often give 600 milligrams of clopidogrel if somebody's going to go to the cath lab immediately. The other way is to bypass the metabolism of that clopidogrel uses, and two drugs do that. Prasugrel is a thienopyridine, in that sense the same family of clopidogrel, but it has a much faster absorption and a one-step conversion to the active metabolite, giving more effective active metabolite generation and a more rapid and greater inhibition of platelet activity. The second drug is ticagrelor, which is also rapidly absorbed and goes through a rapid activation into the active metabolite, which again gives a rapid, consistent, and better platelet inhibition than clopidogrel. These two drugs have then been studied in several large studies and have demonstrated that they've been superior to clopidogrel. The first study was the Triton-TIMI-38 study that looked at clopidogrel versus prasugrel and found almost a 20% reduction in cardiovascular death, MI, and stroke in those patients who were undergoing planned PCI for their acute coronary syndrome, so a clear benefit in this population. The Plato study looked at ticagrelor versus clopidogrel and again found a excellent, almost more than 15% reduction in cardiovascular death, MI, and stroke with ticagrelor versus clopidogrel in a large population of patients with non-ST elevation acute coronary syndrome and ST elevation MI if they're going to PCI, so a bit of a broader population. Based on these studies, the most recent American Heart Association, American College of Cardiology guidelines for the treatment of unstable angina non-ST elevation MI recommend a loading dose of aspirin and then a maintenance dose of 81 milligrams. Clopidogrel as the option for daily maintenance in those patients who can't take aspirin. And then they recommend a P2Y12 inhibitor in addition to aspirin for up to 12 months for those patients who were treated with an early invasive or ischemia-guided strategy, meaning they went to the cath lab. And for that upfront treatment, clopidogrel and ticagrelor is the recommendation. If somebody actually gets a stent or is going for a stent, the recommendation is either for clopidogrel, prasugrel, or ticagrelor for at least 12 months. And there is recognition that ticagrelor is preferred to clopidogrel for patients treated with an early invasive or ischemia-guided therapy. And so most institutions, usually for ST elevation, it's MIs, and acute coronary syndrome do have a preferred agent that they like to use. Typically it's ticagrelor or prasugrel in most patients and clopidogrel in patients who may have higher bleeding risks. In terms of anticoagulants, really the most commonly used drug remains unfractionated heparin, which is given for at least 48 hours or until the PCI is performed. Enoxaparin can be used, but is typically not used because of difficulties managing anticoagulation during PCI. Bivalirudin is been shown to be as effective as unfractionated heparin and perhaps have lower bleeding risks, although there is the risk of an early thrombosis with bivalirudin therapy alone. And in the United States, fondaparinux is not used at all because it needs additional anticoagulation during PCI. Now, who should go to the cath lab for non-ST elevation acute coronary syndromes? An early invasive strategy, which is defined as a diagnostic angiography with the intent to perform revascularization, is indicated for those patients who have refractory angina, hemodynamic or electrical instability, or in the initially stabilized patients who have elevated risk of clinical events. And so here's the algorithm from the guidelines that show two strategies: ischemia-guided strategy, which really is a strategy where you are managing symptoms and not immediately going to the cath lab, or an early invasive strategy on the right. And here are the different therapies that are recommended for these different pathways in terms of aspirin for everybody, P2Y12 inhibitor in addition to aspirin for everybody, and then the different anticoagulation options based on what your strategy is going to be. Anti-ischemic therapy, really to treat the pain, should be centered on drugs that we know will reduce the oxygen and supply mismatch. And so nitroglycerin is indicated either as sublingual or as intravenous for the first 48 hours for persistent ischemia, heart failure, or hypertension. What it usually means these days, if somebody has recurrent chest pain in the hospital, one would start nitroglycerin as one's calling the cath lab to activate for potential revascularization. Beta blockers is still recommended in patients within the first 24 hours of presentation unless there is evidence of heart failure, a low output state, or increased risk for cardiogenic shock, which could include things just as a high heart rate or a relatively soft blood pressure or any other relative contraindications. The recommendations are not to give IV therapy with a beta blocker in patients who have heart failure or low cardiac state in particular, because one can decompensate a patient with IV beta blockers if they are already on the edge. ACE inhibitors and ARBs are cornerstones in the long-term management of patients with large heart attacks and reduced ejection fraction, and therefore ACE inhibitors should be administered in those patients with evidence of pulmonary congestion or an EF less than 40%, or in the absence of hypotension. ARBs are also indicated for those patients who are ACE inhibitor intolerant, and as well as have clinical and radiographic signs of heart failure or an EF less than 40%. And long-term aldosterone antagonists are indicated in those patients who are on an ACE inhibitor, have an EF of 40%, have no significant renal dysfunction or hyperkalemia, and have symptomatic heart failure or diabetes. So one question that comes up a lot is how to balance the ischemia risk versus the bleeding risk. And the problem is, if we look at the major risk factors for cardiovascular events, it's age, prior heart disease, CKD, heart failure, EKG changes, elevated troponin. If we look at the bleeding risk, it's almost exactly the same: age, CKD, hemodynamic changes, history of bleeding, other comorbidities. And so when we consider the degree of anticoagulation that we use, we have to make individualized decision makings regarding the use of catheterization and antiplatelet therapy, and recognize that those patients who are at higher risk of cardiovascular events and may benefit most from the more aggressive therapies are also those patients who are at greatest risk sometimes for bleeding. So let me switch now to the ST elevation MI patients. And we separate this because that initial ST elevation by the ECG, which should be identified within the first minutes of contact with medical personnel, really is the initial and most important triage checkpoint in the evaluation of somebody with suspected an ischemic syndrome. Now, over many decades and many different trials, it's been shown that primary PCI is better than fibrinolysis in terms of lower rates of death, recurrent MI, lower risks of stroke, and at the cost, though, at a higher risk of intracerebral hemorrhage. Now, PCI is better than fibrinolysis, but especially when done early. And if you look at a study where you try to identify when PCI ceases to be better than fibrinolysis, it's about at the 120 mark, 114 to be exact. And before that 114 mark, PCI is better. When you get after that mark, so 120 minutes after symptom onset, then the benefit of any revascularization starts to decrease because there already probably has been extensive necrosis. And PCI may not be better than fibrinolysis. Now, for the management of ST elevation MI, the recommended uses of drugs really are unfractionated heparin with and without a 2B3A inhibitor, or bivalirudin. And those are the two agents that are most commonly used in the United States for the treatment of ST elevation MI. Everybody, again, gets a loading dose of aspirin and then aspirin afterwards. And for those patients who are getting PCI, they either should get clopidogrel 600 milligrams, prasugrel 60 milligrams, or ticagrelor 180 milligrams. And again, most institutions in their STEMI guidelines or STEMI pathways will choose one agent as their agent of choice. Clopidogrel was shown to be better than placebo on top of aspirin in a large study of almost 45,000 patients, where there was a reduction in cardiovascular death among all patients treated for myocardial infarction. And the treatment, really summarizing for STEMI, is aspirin is for everybody. One must decide early on a reperfusion strategy, and by and large, almost everybody should be considered for reperfusion strategy. Primary PCI is the goal, and the treatment if the door to balloon time is less than 90 minutes. In patients where the delay to the door to the balloon because of transport or some other technical reason is more than 90 minutes, and one should think of lytics. Clopidogrel, prasugrel, or ticagrelor should be used, and enoxaparin, unfractionated heparin, or bivalirudin are the anticoagulants. If lytics are being used, then the door to needle time should be less than 30 minutes. Patients should get clopidogrel 300 milligrams with their lytics, and then followed by 75 milligrams, and then they can be treated with enoxaparin, fundaparinox, or unfractionated heparin, and then one should monitor for ST resolution in case they do need an emergent catheterization. Beta blockers are indicated if there's no evidence of heart failure or shock, and early ACE inhibitor or ARBs should be used for ejection fractions less than 40% or signs of heart failure. Now, when we look at the different ADP antagonists in ACS, this is where it does get confusing, and I put this slide in just to compare clopidogrel, prasugrel, and ticagrelor. The advantages of clopidogrel these days, it's once daily, there's a lot of evidence for it, and it isn't a generic option. The cons for clopidogrel is the interpatient variability, the relatively slow onset of action, and the fact that it's a moderate inhibitor of ADP. Prasugrel is a once daily drug. It's potent, there's minimal variability, it has a fast onset, and it's been superior to clopidogrel. I'd say the biggest cons are that it increases non-surgical bleeding. It should not be used in patients with prior stroke or TIA. And it's probably similar to clopidogrel in those patients who are over 75 or less than 60 kilos, and it's no generic. Ticagrelor is very potent, again has minimal variability, fast onset, and superior to clopidogrel. It also increases non-surgical bleeding risk. There's no generic, and it is a twice daily drug, BID drug. And it does have a side effect, which is dyspnea, which usually goes away after the first week or two. In terms of secondary prevention after acute coronary symptoms, which really is focused on the medications, aspirin, ADP inhibitors, beta blockers, statins and all, and high-intensity statins, ACE inhibitors, and aldosterone inhibitors for the appropriate patient. And our goals really are to get the LDL now as low as possible, blood pressure less than 140/90, total tobacco abstinence, physical activity, weight management, optimal A1C control, as well as annual influenza immunizations. Now, a couple other topics that come up a lot with the ICU management of acute coronary syndrome. What do we do with patients who have had a cardiac arrest in the setting of ST elevation MI? Therapeutic hypothermia or targeted temperature management should be started as soon as possible in comatose patients with ST elevation MI and out-of-hospital cardiac arrest caused by VF or pulseless VT, including those patients who undergo primary PCI. So the cooling should happen at the same time that they're going for PCI. and immediate angiography and PCI, when indicated, should be performed in resuscitated out-of-hospital cardiac arrest patients whose initial ECG shows ST elevation MI. These patients have the best chance of neurologic benefit, and treating their myocardial infarction is key to their recovery. Cardiogenic shock is now less frequent in MI, but we still see it for sure. And it is a cascade of events that is caused by myocardial infarction, myocardial dysfunction that leads to both systolic and diastolic dysfunction, leading to decreased cardiac output and stroke volume, increased left ventricular end diastolic pressures and pulmonary congestion. All of this leads to decreased systemic perfusion, decreased coronary perfusion, worsening ischemia because of decreased coronary perfusion pressures, and progressive myocardial dysfunction and death. There also is in this an incredible inflammatory response that can cause vasodilatation in addition to low cardiac output. Revascularization and relief of the ischemia is the key therapy in somebody in cardiogenic shock in the setting of an MI, and has been indicated and shown to improve cardiac output. So the guidelines for shock in STEMI is emergent revascularization after STEMI, irrespective of the time delay from MI, fibrinolytics for those patients who are unsuitable candidates for PCI or CABG. A balloon pump has a class 2A indication for cardiogenic shocks who do not stabilize quickly, and alternative left ventricular assist device for circulatory support should be considered for refractory cardiogenic shock. And this is one of the areas that's had the greatest expansion in terms of therapeutic options over the last decade. And we see now, if we look at the percutaneous left ventricular support that we use in the cardiac intensive care units, ECMO has been around forever and actually is now having a greater resurgence. The balloon pump was introduced in the 70s, and anybody who does a catheterization can put a balloon pump in and temporize, even though the data for balloon pumps has actually been quite limited and underwhelming. Coronary peripheral bypass came through in the 80s. What we really are looking now are two percutaneous event type of VADs. The tandem heart and the Impella are the most commonly used, and they are basically just help to support the left ventricle and right ventricle if needed with mechanical support. ECMO can be used in these situations as well if there is also pulmonary failure, respiratory failure as well. So take-home messages are most patients with acute coronary syndrome should be treated with 2 antiplatelet agents and 1 IV anticoagulant. In ST elevation, immediate reperfusion is the goal. Primary PCI is preferred if the door to balloon time is less than 90 minutes. In non-ST elevation acute coronary syndrome, invasive management for high-risk patients. And then in acute coronary syndrome complicated by cardiogenic shock requires pharmacologic revascularization and occasionally left ventricular mechanical augmentation with percutaneous VADs. So question 1, which of the following drugs is a P2Y12 inhibitor? 1, aspirin, 2, bivalirudin, 3, abciximab, 4, dabigatran, or 5, ticagrelor? The answer is 5, ticagrelor. It blocks the P2Y12 inhibitor, and it works similarly to clopidogrel and prasugrel. Question 2. Which of the following antiplatelet therapies should not be used in a patient with a history of stroke? 1, ticagrelor, 2, abciximab, 3, prasugrel, 4, clopidogrel, and 5, aspirin. All of these agents are antiplatelet agents, but prasugrel is the one that should not be used in patients with a prior history of stroke or TIA, because in that population there was a high risk of intracranial bleeding from the Triton TIMI 38 study.